We are proceeding to the next important topic as well. Just now we talked about the Malay population, so that is important. It is important that we will be have a really closer look to Malaysia, because the next topic you'll be having a chance to see the big picture, the current update on pharmacogenomics in Malaysia that will be presented by the representative from the University of Malaya. Ladies and gentlemen, we're glad to have you here, Dr. Shamsul bin Muhammad Sen.
Good morning to all CFAM and non-CFAM members. I pray that you and family are healthy and safe during this pandemic. It is a great honor to be here amongst you virtually. I am for sure very delighted to be invited as a speaker for this meeting to talk about the recent pharmacogenomics update in the Malaysian perspective. So these are the outlines of my talk. I will try to cover an essential update on the followings. The first being the perception and adoption of pharmacogenomics in the country, and the second would be the current pharmacogenomics research by our team. So where are we now, the Malaysians? So in order for us to fully grasp the acceptance of pharmacogenomics in the Malaysian setting, it is important that we look at the public view, in this case the stakeholders, the healthcare professionals that include the physicians and pharmacists, and also not to forget the patients themselves. Once we know the perceptions of pharmacogenomics, only then we would be able to tell how far Malaysia in the field of pharmacogenomics, whether we have made a significant progress or are we still at the same pace. I would like to refer to this one particular study carried out by Banur et al. On the pharmacogenomic-based practice in Malaysia, the attitude, knowledge, and adoption by the healthcare professionals. First, what they did was they carried out a small pilot study and then followed by circulation of questionnaires to the 1,500 physicians and pharmacists working in Malaysia. The response was not that overwhelming, but acceptable in my opinion. About one-third were respondents, and these respondents consisted of two-thirds pharmacists and one-third physicians. Fair enough. And of course, the respondents' characteristics were spread in terms of gender, age, ethnicity, number of years practicing, whether they come from urban, suburban, or rural area, their primary employers, whether government or private healthcare, and so on. The chart here captures responses by these respondents on several components of attitude, knowledge, and adoption. The majority didn't believe it could save cost and time. Their perceptions of the cost could be due to that they expect pharmacogenomics to be more cost-effective in the long run, but for short term, it will directly cost more than existing options and requires initial financial expenditure. About equal number of respondents support the idea of having a full financial coverage for pharmacogenomic testing. This probably comes mostly from the government employees. Insufficient coverage is one of the main causes of non-adoption of pharmacogenomics in Malaysia. These 50% respondents also had no prior pharmacogenomic education. Large percentage of respondents, over 90%, claimed that their patients benefited from reduced drug toxicity, and over 90% also had poor to fair knowledge of pharmacogenomics. Or, you put it another way, about 10% have good to excellent knowledge. Unsurprisingly, 90% of whom were pharmacists and only 10% physicians. And those with good to excellent knowledge of pharmacogenomics were so much younger and at their early career life, which makes sense since how relatively new the field of pharmacogenomics is, and this younger generation could have been exposed to pharmacogenomic education during their studies. But in overall, the pharmacists tend to score better than the physicians. I would like to refer to one other study on determinants of stakeholders' intention to adopt pharmacogenomics in Malaysia, which was recently published in the Pharmacogenomics journals in May 2020. They identified two stakeholder groups made up of healthcare providers who were directly involved in medical genetics, and another group being the patients with genetic diseases or their family members. This diagram is the proposed conceptual framework and factors influencing stakeholders' intention to adopt pharmacogenomic testing in Malaysia. There are several determinants that eventually project to the same goal, which is the intention to adopt pharmacogenomic testing, such as engagement of medical genetics, trust in key players, in this case, doctors, the healthcare providers, religiosity, and so on. There are also chances where one determinant may potentially affect other determinants in between. Based on the report, they discovered that in average, respondents have moderate level of engagement of medical genetics, and this sort of information tell us that better engagement in medical genetics will be positively associated with a greater intention to adopt pharmacogenomic testing. The same moderate score was reported for other two determinants such as perceived risk and perceived moral concern. So we Malaysians put our trust highly in our physicians, and I guess everyone else does. It's just that doctor's word sounds very convincing to us, and that's why you can see that the score is relatively high for this component. And so does for religiosity, which plays important roles in people's life. Although the results showed that the stakeholders in Malaysia are very positive toward pharmacogenomics testing, they were also very cautious about it. That's why you can see that we are still at the moderate to high level. We're still not at the full adoption of pharmacogenomics in our life. I can summarize that the pharmacogenomics challenge that we are facing right now relies heavily on the decision by the higher authority. Unless these top-level people start to introduce a policy that favors the deployment of pharmacogenomics, then for the next 5 or more years, we will see little to no movement at all. I like the idea how the US president back then, Obama, launched the precision medicine and how this brought a change to pharmacogenomic landscape in the US. And not to forget our neighboring country where the Thai scientists work closely with the ministry and also change the pharmacogenomic landscapes in their country. Besides, our national strategic plan seems to favor cancer and non-communicable disease studies like diabetes, obesity, hypertension. We have yet to have a proper plan for pharmacogenomics at the moment. And at the moment, we seem to give a good training to the young doctors on pharmacovigilance, but not pharmacogenomics. The cost of pharmacogenomic testing is not covered under our healthcare system, which further dampens our adoption of pharmacogenomics in Malaysia. To make it worse, our data on cost-effective studies were not looking good either. This study by Chong et al. On the cost-effectiveness of HLA B5801 testing before allopurinol therapy for the prevention of Stevens-Johnson syndrome toxic epidermal necrosis found that if you compare with current practice, which is prescribing allopurinol without genetic testing, the HLA B5801 allele screening before allopurinol initiation resulted in 0.252 calorie loss per patient at an additional cost of USD 879. Whereas the alternative therapy by probenecid resulted in 1.928 calorie loss per patient at an additional cost of USD 6,848. The conclusion was made that it is unlikely to be cost-effective intervention in Malaysia. The same goes for another similar type of study looking at cost-effectiveness of HLA-B 1502 testing before carbamazepine therapy, and they found that it is unlikely to be cost-effective intervention in Malaysia either. I believe this is what made our scientists being restricted from to go forward and speak to the top level people about the full adoption of pharmacogenomics in Malaysia. As mentioned earlier, lack of support and knowledge amongst the healthcare providers is another challenge facing. And lastly, we don't really have a beautiful culture of sharing research information amongst the institutions and also amongst the peers. And now, I would like to jump into some of the recent pharmacogenomic research we have completed in the lab. We don't really have many, and the lab has been doing well on genomic research, but less on pharmacogenomics due to difficult funding, especially nowadays the university is emphasizing on fundamental research. And the very first one that I want to show here is this study by one of my students on the CYP3A5 genetic variants and their associations with carbamazepine and valproic acid monotherapy response in Malaysian epileptic patients. What do we know about epilepsy in Malaysia is the patient made up about 1% of overall population, with a relatively similar prevalence in other countries around the world. And genetics variants within CYP3A5 may affect individual response to anti-epileptic drugs through alteration of the CYP3A5 enzyme activities, which is involved in the metabolism of most anti-epileptic drugs. Hence, the objective is to evaluate the association between CYP3A5 variants. In this case, those variants identified are RS776746 and RS1419745, and response to carbamazepine and valproic acid monotherapy in a cohort of Malaysian epileptic patients. And the study recruited a total of 288 epileptic patients, and they were then genotyped for CYP3A5 RS776746 and RS1419745. Of the 288 patients, 60 patients were on carbamazepine monotherapy and 85 patients were on valproic acid monotherapy. If you look over here in the table, these two drugs were top in the list. In this study, we found a significant association of CYP3A5 RS776746 with carbamazepine treatment response in total patients and Malay ethnic subgroups. Similar findings were seen for this SNP RS776746 with valproic acid response, where significant results were also seen in total patients and Malay ethnic subgroup. However, CYP3A5 RS1419745 was associated with carbamazepine treatment response only in the Malays. Our findings suggest that CYP3A5 polymorphisms affect carbamazepine and valproic acid response in Malaysian epileptic patients. The second study that I want to show here is about ATDL, anti-tuberculosis drug-induced liver injury, and this was also recently published in 2020 by our team. And unfortunately for ATDL, the statistic on the incidence in Malaysia is scarce. We know that genetics risk factors of ATDL includes genes that are involved in the metabolism of the anti-tuberculosis drugs. Hence, we investigated the association of SNPs in the anti-tuberculosis drug metabolism pathway genes with risk of liver injury in the Malaysian population. And the study recruited a total of 90 patients, of whom 15 were cases with liver injury. Cases were diagnosed with rather a stringent criteria where an increase in serum AST or ALT needs to be more than 3 times of upper limit normal, or increase in total bilirubin more than 2 times upper limit normal. We then perform a microarray genotyping of 170 SNPs that are within the same chromosome or pathway of those well-known ATDD-related genes. And the table here shows the demographics and clinical profiles of the subject. They are quite in distribution of of ethnicity there, although they are not making differences in p-value as overall. And if we look at here, controls and cases gender were matched. Looking at the results, we found that NOS2A RS110X0344C allele was associated with more than 2.7-fold risk of ATDD. And to date, there is only one study from the Japanese investigating the association between NOS2A RS110X0344 and ATDD. The authors showed that CC genotype shows a high risk association with ATDD, and this was reported by Nanashima et al. However, the rest of the SNPs in the study, including those well-known ATDD SNPs as listed here, were not significant, and that's probably because of limited sample size in the study, which is considered very small, about 15 cases only. These have become the main limitation of the study, although patient samples were collected from two different centers, the University Malaya Medical Center and Institute of Respiratory Medicine, IRM. IRM is the referral center for respiratory diseases, and majority of tuberculosis cases from Kuala Lumpur are treated here. And the reason why these two centers were chosen compared to other hospitals is because they were actively involved in monitoring and reporting of ATDD cases. Despite low sample size, our study sample size is justifiable. In general, the sample size in pharmacogenomics of ATDD ranges from 18 to 185 for case subjects. Larger sample size is often seen in a study adopted the ALT more than 2 times upper limit normal in defining the case subject. It is also noteworthy to mention that the study by Nanashima et al. On NOS2A had a sample size of only 18 cases using the ALT more than 2 times upper limit normal criterion. Another limitation from our study is we did not investigate the association by racial breakdown, as it will deem a low sample power. Although the incidence and mortality of TB in the country is relatively high, but there is still underreporting when it comes to ATDD cases in the country. So, in conclusion, we suggest that NOS2A genetic variant may play a role in disease modifications. However, the scale of the NOS2A variant effects warrants further studies in the future in a bigger cohort, and this is always a dilemma in any ATDD study because of the limited number of sample size. And with that, I should conclude my presentations, and I'm open for questions. Terima kasih, and have a nice seminar day to all of you. Thank you.
Terima kasih. Thank you very much. Also, that is how we learn about the big picture, the update on the pharmacogenomics in Malaysia. And of course, because this topic is very important, we have got one interesting question for you to elaborate on. The question is, how do you plan to educate your clinicians and engage the support of higher level leaders in clinical implementation of pharmacogenomics in Malaysia?
Hello, good morning. This is V. Shamsul. So the question is on how do you plan to educate the clinician and engage the support of higher level leaders. So truth be told, it's difficult. Based on the data presented earlier, if you look at the data, you will find that over 90% of the Malaysians, the respondents, having poor to um, fair knowledge of pharmacogenomics, and only about 10% of us are having quite okay, moderate to very good knowledge of pharmacogenomics. And these 10% were mainly pharmacies rather than the physician themselves. So the the problem is always with the physicians, and it's very hard for us actually to educate those clinicians, especially those at the mid to long term of their careers, and it's much easier actually to educate these youngsters. And that's why from the data, if you look at that, you'll find out that the respondents were mainly youngest. Okay, and to answer the question, we are slowly implementing or incorporating the pharmacogenomics lesson to the education, okay, for the course, if in the medical practice, or even in the pharmacies, and also in the biomedical program. So even if they don't have that particular course on the pharmacogenomic, but we do have external classes that we actually give it to them. So in the form of current topic, and that will be accessed on that sense. So this is how do we do it. And for us to get the support from higher level of leaders, I think this is the most difficult things to do at the moment, because the politics keeps changing in the country, and we don't really have politicians that coming from a science background, and that's the dilemma, the difficulty that we are facing right now. So they don't really understand the beauty of research, and they don't really understand what's the purpose of doing all this. And for us to have pharmacogenomics implemented at the level of at least tired people, and I think they have to work closely with the ministry, and the ministry have to understand the beauty of all doing of this pharmacogenomic research. Thank you.
Thank you very much. We also have another question for you. You stated that HLA-B 1502 screening is not cost effective in Malaysia. Could you please can the explain that? Can the mortality of patients be compared to monetary terms?
Okay. I know this is if we listen to the presentation earlier from I think yesterday on the cost-effective study in Thai. So the revenue is slightly little compared to the improvement in the quality of life of the patients. But if you look at the Malaysia, because of the budget keep, uh, they keep uh, lowering the budget, especially for the research, and most of our current research uh, on the fundamental aspect, they don't really do any pharmacogenomics research anymore unless you work closely with other group of people. So to answer that, whether the mortality, if you look at if you compare with them the revenue and also the mortality, so which is the one that's weighing the most? Of course, we weigh the mortality rate is something that should be concerned, but the incident. So we base on the data in the if you look at the incidence of all these adverse drug reactions induced by the therapy, we have a very low incidence, and not many of them did capture ADR during their lifetime. But when they did, they have a very severe adverse reactions. And because of these data, we can't really go and tell the ministry and whether we can actually do the pharmacogenomic testing and to implement it at the level. So basically what we do is we do advise the patients, if you happen to have these kind of HLA, so we do advise them, you are likely to have this. So whether they like to change to medication or they like to continue with it, or but of course it's under the recommendation of the doctors as well. And that's how we do it. At the moment we don't really do a routine, even a routine practice in looking at the genetic screening, but at the recommendation by the doctors.